and bathwater, similar kind of concepts. We're going to review some of the babies and some of the bathwater and what you should throw out and what you should maybe keep. Ooh, I got it. These are my disclosures. I hope this is worth 1 CME credit of your time. So my objectives today are for you at the end of this to understand the processes that lead to development of clinical practice guidelines for ILD. They're probably very similar to other clinical practice guidelines, but my experience is in ILD, and I think they might be a little bit unique. Recognize the limitations in the recommendations because there are many, and then to be empowered to implement the ILD guideline recommendations as you see fit, because I think that's also a very important thing to take away from this. So why do I care? So, when I started out in training, this is what I thought of guidelines. I was like, this is the spoken word. This is the ultimate truth. I studied on them. Like my, supervisor would say, you should read the guidelines to understand how to provide clinical care. And then I joined my first guideline committee, and I found myself in the trough of disillusionment. And I was shocked at the things that went on and how voting happened. And then now I feel like I'm kind of coming up to the slope of enlightenment and eventually, hopefully, through the plateau of productivity, and hopefully not just pointing out issues, but also potential solutions as to how we can make these things better. So guidelines are coming out all the time. A recent scleroderma ILD one was just published. And so this is constantly at the forefront of my mind. And I thought it's something that we should talk about. So what are clinical practice guidelines? The Institute of Medicine defines them as such statements that include recommendations intended to optimize patient care, informed by a systematic review of evidence, assessment of the benefits and harms of alternative care options. Really, ultimately, they're supposed to educate, they're supposed to guide us clinically and to define best practices. And I think when we get into our own field, we can look at the guidelines and find that they're very flawed. But if I had to treat somebody with like neuroencephalitis or something right now, I would look to a guideline to help me make that diagnosis and probably help to manage that. So I think people that aren't experts in these areas come to this quite frequently and rely on these guidelines. So to be trustworthy, a guideline should comply with 8 standards. They should be transparent. There should be management of conflicts of interest. The development group compositions should be diverse and representative, informed by a systematic review of the literature, establish evidence for foundations and rating strength of recommendations, articulate the recommendations, be clear. They should undergo external review, and then as appropriate, if needed, and there's new evidence, incorporate new knowledge. So the American Thoracic Society, and I'll focus on the ATS because it's the largest, and I think probably most powerful international pulmonary society, and the one that publishes several guidelines and one that most of us that would be referring to. There's a whole bunch of different documents. So you can have clinical practice guidelines, and those make clinical recommendations. Then there's statements. So clinical statements is like a softer version of a guideline, can still make recommendations, but doesn't require methodologists to be a part of it. You can have research or policy statements, technical statements, and then workshop reports. So this is all the sort of formal documents that our society supports. So it's to make diagnostic and treatment recommendations to assist clinicians essentially to provide patient care. They're developed ideally by a multidisciplinary committee, includes people with prior experience and or a grade-based project. So this is the caveat at the beginning of the IPF guidelines and the HP guidelines. Clinicians should apply these recommendations within a guideline in the context of each individual patient, considering the patient's values and preferences, and should not consider any recommendations as mandates. And I think that's very different than when we're going through training and we're memorizing. So, I still refer to COPD guidelines, and I think, okay, this is how I'm supposed to do things. And they're really taken as sort of the truth, but they really need to be interpreted. These are recommendations. These are, possibly considered best practice, even in the face of very low evidence, and just, take it with a grain of salt and always consider your patient first. So I think that's really important. So these are the clinical practice guidelines in ILD that have been published since 2011. Wait, and then there's 2 more. So we've had 8 clinical practice guidelines published in the field of ILD since 2011. And I haven't read this scleroderma one yet. There's a webinar next week, and I'm going to attend it to get the main basic points. Why is this even controversial? So this man, John Ioannidis at Stanford, published this paper a few years ago, basically saying that guidelines are there to promote self-citation within societal journals, to make it powerful, to make money, to get people to come to the conference. There's sometimes hundreds of authors on these guidelines, and then everybody in the society keeps publishing or citing them, and it becomes this big self-citation machine. I had never thought of a guideline that way before. I was like, what? These are like the best people in the field, and they're all getting together to have meetings and do the best stuff. I was like, whoa, that's a kicker. And so he recommended that professional societies should disentangle these specialists from the guidelines, and maybe you should have some, but they should really be written by methodologists and patients, and then have some content expertise. But he was recommending at that time that societies like the ATS, ERS, CHEST should not be writing clinical practice guidelines. Oh, he said, sorry? Yeah, so that would be some of his chaff. Yeah. Oh, that John also said that COVID was like the flu in 2020. So not everybody is perfect. Absolutely. So I'm going to review 3 sort of chaffy things that I think are problematic about the clinical practice guidelines. One is diversity and representation. One is the document development process. And then one is voting. These are things that I've kind of uncovered, I think, over the last couple of years. So I've highlighted in red, I'm focusing here on gender. I've highlighted in red the women on clinical practice guidelines in 2011. So there's 3 names. Dong-Soon Kim is the only MD on there. The other 2 are the librarians. So you look through the authorship list and you're like, oh, look how many women. So there's 3, but 2 provided the methodologic support. And 1 was Dong-Soon Kim. In 2015, there were no women MDs on the guideline. Again, the librarian who provided the literature review and support. The 2018 Fleischner Society had, again, 1 librarian on there. The Fleischner Society currently still has no women clinicians. There are a handful of women pathologists and radiologists in the Fleischner Society, which is a private closed society by which you have to be invited by members and then voted upon. And then you have a sort of test year after which you may remain in the society. So it's pretty closed. The one in 2018 actually had 5 women, 4 of which were women MDs, and 1 was the co-chair. So I remember sitting in the 2015 at ATS when they presented this, and I was just struck by it. I was like, where are the women? So we wrote a paper in Lancet Respiratory Medicine a few years ago and just looked at all of the major documents in ILD over the prior 10 years. We're starting at the bottom. So on the 2011 guideline, 1 out of 33 authors was a woman. The 2013 IIP guideline, 2 out of 36, 0 out of 21 was a woman MD. In 2015, 0 out of 17, and then 4 out of 34. And if we look at the first or senior position or chair or co-chairs, this is over a 10-year time period that is like in our recent history. Like we're all certainly alive and working in this time period. There has been 1 co-chair as a woman in all these documents. The other thing that I think we don't talk about is that of these 8 guidelines, 6 out of 8 of them have been chaired and first authored by 1 individual. So nobody's talking about this, but I think it's problematic. And maybe people are talking about it, but I'm not sure if it's changing or not. And so from a diversity and representation and multiple voices scenario, it's just very obvious. So the good thing is the ATS has a published diversity and inclusion policy. And there are specific recommendations and there are metrics. And this is beyond gender and sex. This is racial and ethnic minority and underrepresented individuals in medicine, as well as early career individuals and getting trainee involvement. So I'm hoping that over the next couple of years, and I honestly have seen this in the program committee and in the planning committee, when document proposals are discussed, that these issues are actually coming up, and whether they've been fully articulated or are being implemented, I'm not totally sure, but I think we're all reviewing these documents through this lens much more in the last couple of years, and I hope it continues to progress. So the documents development process, it's supposed to be transparent. So I don't know if I've ever proposed a document, but you basically co-chairs propose it to a planning committee. And then the members of the planning committee review them, they rate them, there's all this effort to have like meetings and discuss them. And then they give the recommendation to the document development committee. And you may say, for example, as an example, we think this should not go forth as a guideline. And then the documents development committee decides, and a year later, you're reviewing the renewal, even though you said there's no way this should go forth as a guideline. So there's some lack of transparency. I'm not totally sure who ultimately is involved beyond the document development committee, if it's the board, but it's certainly not as transparent as it could be. As a committee member, you're then invited by the co-chairs, and you have to remain hush hush. There's like an embargo. So I'm not even sure if I'm allowed to tell you that I'm on the IIP guidelines that are coming out. Like you're not supposed to talk about anything. But I think that was established to try to protect people from financial interests but I'm not sure that that works. Everybody kind of knows what's going on, but there's definitely like confidentiality. There's PICO questions. They undergo a systematic review. Those questions are increasingly transparent. They're now part of most of the documents that get submitted at the time of submission. The one I was a part of, they weren't part of the actual proposal. We just kind of made them up on a committee call and then sort of voted haphazardly on which PICO questions we thought should go forth. And then there's literature and voting. So the knowledge translation component, I think this is an area too where we really can be doing better outside of our field, outside of sort of expertise and people who eat, sleep, and breathe, particularly interstitial lung disease. There are a lot of people still getting surgical lung biopsies to diagnose IPF. All the guidelines now say don't do that if you've got a UIP pattern, but that information is not necessarily getting out. And I think we really need to work on our implementation and knowledge translation of this information. So usually the chair will present at ATS. There's some online webinars. They're published in the Blue Journal. And then recently, so there's a summary for clinicians that's really helpful. And then each PICO question has a systematic review and meta-analysis, and they're mostly published in Annals of ATS. And that gives they're peer reviewed, but they're pretty much going to get published because they're generally pretty well done and they're informing the guideline. But then you can go back and look at each of the systematic review questions and then get like a full systematic review understanding of the literature. So the problem I think so people hate us, right, in ILD, and I think some of the problems from the guidelines is that I think we've really alienated a lot of the field by introducing new acronyms and then changing things and splitting hairs. And the general community clinician is like, well, I don't know what I'm supposed to do with this information. So I think we really need to focus on the end user of the documents also, as opposed to sort of getting our academic slicing appropriate in our minds, always keeping the patient at the front and center of this document development, because the end user is clinicians, or are clinicians who are going to apply this to patient care. So the third part is voting. So recommendations are born in the guidelines using a voting system. And this was what was used in the 2022 IPF and PPF one. So basically, if there's a committee and everybody gets to vote mostly, if over 20% abstain, then there's insufficient quorum and a research recommendation is made. If less than 20% people abstain and greater than 70% agree, then a recommendation is made, either a strong recommendation or a conditional recommendation based on the quality of evidence and the strength. If there's less than 20% abstain and less than 70%, no recommendation is made for or against. But it's interesting how the conflicts of interest are managed. So management of conflicts of interest is a guideline, or not a guideline, a standard for the transparency of guidelines from the Institute of Medicine, but how that's managed can be really variable. So in 2015, for the treatment of IPF, no committee members with any conflicts of interest were allowed to vote on the recommendation. So if I were on that committee, I wouldn't be allowed to vote. I have multiple conflicts. In 2022, they changed that. So more than half of the guideline committee and the co-chairs could have no conflicts, but everybody on the committee was allowed to vote. And I think it's because of this example I'm going to give. So the 2015 treatment of IPF guideline, I'm going to highlight the one recommendation for antacid use. So it didn't change from 2011 to 2015. There was a conditional recommendation for use. For anti-reflux therapy, essentially proton pump inhibitors or H2 antagonists to treat IPF. There were 21 guideline committee members, 8 pulmonologists with content expertise in this area, and none of them were allowed to vote. So they could participate in discussion of the evidence, but they couldn't vote on any recommendations. They could only stay in the room for the discussions if they were explicitly asked. And this is how the guideline recommendation came out for this question. Should patients with IPF be treated with anti-acid medications? We suggest that clinicians use regular anti-acid treatment to treat patients with IPF. So I have received, multiple second opinions about treatment or management diagnosis of IPF patients, and they all come to me on a PPI in the absence of any history of acid reflux or any symptoms of GERD, because that was in the guidelines. So this would have led to tens of thousands of people, probably around the world, getting started on antacid therapy. And what's interesting is Kevin Wilson is the lead methodologist. He's amazing and brilliant and is the lead methodologist for the document development at ATS. He went back to all of the committee members after this and said, if you were allowed to vote, how would you have voted? Nothing would have changed, except this is in a footnote in the guideline. The conflicted experts would have made no recommendation. So had they been allowed to vote on that particular PICO question, there would have been no recommendation for or against, and potentially spared thousands of people from being put on a PPI needlessly based on a lack of evidence. So I think it's just really interesting how these things, you're like, oh, this is like the truth. This is the gold standard. You're like, well, it's kind of a nuanced way to get at a recommendation that's really impacting patient care. But still, there's really good things about clinical practice guidelines because there are so many unknowns and there's really poor evidence base for the diagnosis and management. And if you really want to apply evidence-based care for your patients, a lot of what you're going to be doing is a whole lot of nothing, which might be okay in some scenarios, but we really lack a lot of evidence. What these guidelines provide to clinicians worldwide is sort of a best practice, hopefully from global expertise. And there's been guidelines on IPF, HP, systemic sclerosis, IIPs, BAL, sarcoidosis, LAM. Clinicians worldwide, I think, appreciate this knowledge and appreciate these documents. I know I certainly do outside of my field. So I think they serve a really good purpose because we're actually not sure about a lot of what we do. I think people just want to know they're not doing anything wrong. So HP was an area that had abysmal agreement on the diagnosis of it. And this led to, so this was a study from Simon Walsh that looked at multiple multidisciplinary teams, and nobody could really agree. The clinicians, radiologists, and pathologists, and the MDTs, I mean, they had a weighted kappa of 0.29. It's pretty abysmal. This was in 2016. Nobody could agree on what HP was. And if you've ever tried to publish a paper in HP and then everybody's like, oh, I don't think they have HP, it was really challenging. Like if you sent it to a European journal, but you didn't do BAL, it wasn't HP. If you sent it to an American journal, but you didn't have biopsy, it wasn't HP. So then we had this veritable cornucopia of guidelines that came out in 2020. And I think they've served a really good purpose, but they send some shared messages and some different messages. So these are the diagnostic algorithms that came out of each of these with the ATS one, ATS JRS ALAT one, called the ATS one on the left, and then the ACCP chest one on the right. So these were the PICO questions that went into the ATS guideline about formal exposure questionnaires in HP, serum-specific immunoglobulins, BAL, transbronchial biopsy, cryobiopsy, and surgical lung biopsy. And the chest one took longer because there were more PICO questions, and actually kind of a very thorough review of the literature with really strong methodologic support at ACCP that kind of went through a lot of these and some additional PICO questions. So they all basically agreed, well, both basically agreed that exposure assessment is important. Everybody should take a thorough history, should use a questionnaire. That would be great. At the time, there wasn't a validated one. Probably look for occupational HP, get an industrial hygienist involved, and then classify based on the inciting antigen. The difference being ATS says exposure, yes or no, and the chest one says identified, indeterminate, which is probably where most of us sit, and there's an algorithm for that, versus unidentified. And I think that's actually more nuanced and probably more clinically applicable. Everyone says don't do inhalational challenge testing, don't do lymphocyte proliferation, and don't rely on improvement with antigen avoidance, particularly in fibrotic lung disease. Oh, and I just wanted to highlight, so there is this chest HP questionnaire. There's a newer one from Haley Barnes that's been published and then validated. And we developed this website called hplung.com. That's just like a free online, it's kind of like pneumotox, but for HP. So you can go and see if your patient's exposure has ever been reported in the literature. So we're trying to help find some exposures. Essentially, the serum-specific immunoglobulin, this is where things aren't congruent between the two. So the ATS guideline suggests performing IgG testing. Very low confidence in estimates. The chest guidelines suggests don't rely on it entirely. I'm like, well, okay, so I mean I do it or I don't do it. I think it could mean either. You could do it, and then if it doesn't show you what you want, don't believe that. If it shows you what you want, then believe that. So I think it leaves all this kind of open for interpretation. And actually the evidence for immunoglobulin testing in HP is really poor. If you review the data, there are only 3 studies included in the systematic review, and they don't perform well. So I don't know, clinically people say it's helpful. The data don't support that it's actually really helpful. So cellular analysis is another place that things aren't really congruent. So in ATS, they recommend it for non-fibrotic HP and suggest it. So kind of like a softie, you could do it for fibrotic HP, and they say to use a 30% threshold. The chest says don't routinely do it. Don't do it to confirm a diagnosis. If you know this person has HP, don't do a BAL. They didn't propose a cutoff. If you want to do it, you can. It might be supportive, but the absence of lymphocytosis doesn't rule it out, and the presence doesn't mean that it's HP. We did a systematic review and meta-analysis using individual patient data on BAL lymphocytes and chronic HP, and really found that a threshold of about 20% worked best. There's a lot of confirmation bias in all of these studies. It's kind of limited by the parent data, but based on what we had, 20% seemed to perform the best. So using a 30% threshold probably increased your specificity at a loss of sensitivity. So not totally sure where that came from. Probably the best thing that came out of the HP guideline was this definition of what is an HP pattern. And this is fairly consistent across both guidelines. Just examples of no zonal predominance, reticulation, minimal honeycombing, and then these beautiful CT scans with lobular areas of hypoattenuation. So mosaic attenuation on inspiration and air trapping on expiration. This has now been defined as like this HP pattern. What we are finding in some of our registry data, one paper Daniel Marinescu just published in Chest shows that if you have a typical HP pattern, about 30% of people actually don't have HP. So is it a typical HP pattern, or should we be calling it something else? Because we're giving it a diagnosis name in a radiographic description. So I think it was helpful, but I think still requires a little bit more nuance to clarify what this pattern means. And then agreed upon recommendations for biopsies. So transbronchial biopsy, cryobiopsy, surgical biopsy. Don't do them until patients have been reviewed in a multidisciplinary discussion. That was the message from both, to determine if it's actually needed or not. So multidisciplinary discussion, that is a key of both of these diagnostic algorithms before going for a biopsy and then after the biopsy has been done to be reviewed with expertise. So the issue, one of the big issues with this guideline for HP is you can't make a definite diagnosis of HP without a surgical lung biopsy. So this was kind of like, I don't know, I feel like this is a really big issue. And so anything over 90% confidence, I don't really know what that means. I think confidence is actually more a factor of the clinician rather than any other feature. And I think it depends on how you woke up that day. So I've always kind of wondered of what are we talking about this diagnostic confidence? Like what's 68% versus 75%? Like I'm feeling pretty 75 today, but yesterday I was 68. So I'm not sure how much this helps, but I certainly don't think that this should be used for, if, for example, a clinical trial of HP, we're not going to say, oh, you can only include definite HP, and they all had to have had a surgical biopsy because that's a completely different target group of patients. Whereas in the chest guideline, if you have an identified exposure, if they have a house full of parrots and they have a typical HPCT, that is HP. You don't have to do a bronchoscopy, and you should, they're being reviewed at the multidisciplinary discussion. You don't have to do a BEL. You don't have to send serum immunoglobulins. You don't have to do a lung biopsy. This is, I think, much more seems to make a little bit more sense. And using some of the data from Moises Selman in Mexico City, we reviewed 144 patients that had a diagnosis of HP from their cohort. And they all have a pretty standardized approach. Not all of them have biopsies. Only 18% of the cohort had biopsies. And then we classified them using these two guidelines. So we used the ATS one and the ACCP one, and they all got classified pretty well, except with the ATS, only 18% could have definite HP. 42% could have high confidence, 34% had moderate, whereas in the chest guidelines, really that's, 92% had high or a definite of HP. So those are all the same patients. So I think what I'm not understanding is why we're breaking things into definite versus HP, high and moderate confidence versus just like high confidence, and why we're sort of splitting hairs over these different diagnostic thresholds, because I'm not sure that that's clinically helpful. So the takeaway points from this guideline that I think are actually really helpful, definitely try to find an antigen, mostly by taking a history, potentially using a questionnaire if you've got one that is applicable to your site. Definitely get an HRCT and review the patient in multidisciplinary discussion. In some circumstances, BAL might be helpful, IgGs, histopathology, sometimes improvement with steroids or antigen avoidance. But again, there's all these key differences, and I think people will apply whichever one seems to suit their practice better or suit their study better, because I'm not sure that one is superior to another or that we can actually say. So I think I'd focus on the things that overlap as opposed to the things that differ, because I think those are still questions. So this brings us to the most recent major guideline that has come out from the ATS, the 2022 updated IPF guideline and progressive pulmonary fibrosis guideline. So there were two parts to this, the update on the treatment and diagnosis of IPF, there's the narrative, and then there was the guideline part. And then the second part, there was the diagnosis of progressive pulmonary fibrosis in fibrotic ILD other than IPF, not IPF. So there's the narrative part, and then there's the PICO questions, of which there's two. So this is how the voting went on the IPF guideline for the 4 PICO questions. So basically, cryobiopsy, can be considered equivalent to a surgical lung biopsy. And this is how people voted. So 94% of the committee members thought that was a reasonable approach. The genomic classifier is very meh. I'm not sure it was maybe it was a key PICO question to include in an updated guideline. They suggest now not treating patients with IPF with PPI, so the evidence was weighted heavily against doing that, and then not referring patients for surgical lung biopsy or for an anti-reflux surgery, so a fundoplication to treat their IPF. And this was all to, again, bring a diagnostic algorithm that really is no different from the 2011 one, except now transbronchial cryobiopsy is on there, but it's very similar. But I think one of the frustrating things is the guideline includes a lot of information, and what people go to, what clinicians go to, are things like this. And these are not rooted in any evidence. So we spend all this effort trying to address PICO questions. I mean, I guess treating comorbidities seems like a really logical thing to do, but we don't know that that impacts patients' outcomes necessarily overall if you treat sleep apnea in an IPF patient. I mean, if you're treating the sleep apnea, it's probably important. But treating GERD, again, these are just like kind of common sense things. I think these other two consider, even the way it's worded, consider annual HRCT if there is clinical suspicion of worsening or risk of lung cancer. This is essentially recommending screening for lung cancer in our IPF patients. There's like no data for that. And we know these patients are at risk for cancer. We don't know if an annual, first of all, it's not an HRCT. We don't know if an annual CT scan is going to have any outcome or positive beneficial outcome, but that gets tucked into the guidelines. And I thought you'd appreciate this one, Naftali. Acute exacerbation corticosteroids somehow makes it all this effort to provide evidence-based recommendations. And then in this figure is recommended something that is quite likely harmful with no evidence to support that recommendation. That's just like, I don't know, all this other stuff seems to get tucked into these other things that seem to have a really robust evidence base where you're trying to provide good care. So that's a chaffy thing, I think. So limitations of these guidelines, I feel a little confused. So the PICO questions were of ILD of undetermined type, whereas the prior ones were in patients with suspected IPF. Are we applying these guidelines to patients with ILD of undetermined type or people with suspected IPF? Those are two very different populations, and it's a nuanced interpretation of the guideline. I'm not sure why cryobiopsy was included in there or the genomic classifier. I think the best thing that came out of it was this PPI recommendation. The anti-reflux surgery data, I don't know. I think there's some pretty good data to show that it might be helpful, but I get where it wasn't on there. There was nothing about biomarkers and nothing about serology, which are two really important questions in the field that I think should have been in there. And maybe we weren't ready for an update if nothing really changed and we didn't address some of the key problems. So what got tucked into the guideline, and this is actually written in there, so I'm not like telling any secrets, but it was proposed as an IPF guideline and it was approved as an IPF update guideline. And then what got tucked in there was because there was progressive fibrosing ILD trials came out, that all of a sudden they were like, well, let's tuck this into the guideline, even though it may or may not be ready, which I don't think it was ready at all. But progressive fibrosing ILD is an entity. Patients with pulmonary fibrosis get worse. And there have been all these different definitions across clinical trials, and nobody could quite make sense of what they were. So this definition came out of this recent guideline. So basically, progressive pulmonary fibrosis, or PPF, it's disease progression in fibrotic ILD, but not IPF. You have to exclude other causes of worsening. It's not a diagnosis. And everybody already talks about it like a diagnosis. I've had chest x-ray reports that have given it back to me as this patient has PPF. So I think it's a real nuanced thing to say this is not a diagnosis when being applied to the clinical world. It's agnostic to the underlying conditions, so it can be basically anybody except IPF, and that the criteria should come from multiple clinical trials. So they say this should not determine who should get an antifibrotic. They're prognostic only, and we're not meant to use these criteria to determine who should get an antifibrotic. And yet the only two PICO questions in there are about antifibrotics and who should be treated. So it's just kind of interesting. So this was not based on a PICO question or voting. I don't know how this definition came about, but this is the definition. In a patient with ILD of known or an unknown etiology other than IPF who has pulmonary fibrosis, you have to have at least two of the following three in the past year. So again, that time frame of 12 months was somewhat arbitrarily chosen. It wasn't 6 months, it wasn't 24, it's 1 year. I'm not sure how that was decided. Worsening respiratory symptoms, physiological evidence of disease progression, either of those, and then radiological evidence of disease progression, one or more of the following. So in a very evidence-based world, these are just kind of put out there. So, I mean, there are ways to quantify dyspnea worsening, cough worsening, exercise intolerance progression, and fatigue, but there was no quantification of that in the guidelines. So it's just sort of, if anything, if this is happening in your patient, you feel like you've reasonably excluded any other cause, that counts as this respiratory symptoms worsening. The physiological progression is absolute FVC decline greater than or equal to 5% within 1 year, or absolute DLCO decline greater than or equal to 10% within 1 year, which probably seems reasonable. These are largely extrapolated from IPF data. Did not include hospitalizations, 6-minute walk distance, new hypoxemia, or acute exacerbations. And the radiological progression. I think this all makes reasonable sense. Again, there's a lot of subjectivity. When I look at something, I interpret things very differently than chest radiologists. I'm still working on that. But I think the technique can be different. The person looking at it can be different. And so when I think we just kind of interpret this, and I'm a big fan of the Gestalt, and I know you can't apply a Gestalt to a clinical trial inclusion-exclusion criteria, but that's not what these are meant to be for. So there were 2 PICO questions included in here. Should we use pirfenidone to treat progressive pulmonary fibrosis? This is based on a systematic review, meta-analysis consideration of 2 studies. 2 studies that I think were underfunded, tried to recruit during COVID, were stopped early, didn't meet their primary endpoints, but met their secondary endpoints. And if you look, everybody who voted was conditionally for pirfenidone to treat PPF, but 13 out of 34 participants abstained from voting. So it led to a research recommendation. So this is why pirfenidone is not recommended. I don't know how this would have affected funding necessarily anywhere. It may have, if this had said, we recommend this, that maybe in some places that would have made pirfenidone accessible to patients that met these criteria. But based on these evidence, they recommended further research into the efficacy, effectiveness, and safety of pirfenidone in all these ILDs. This is a systematic review and meta-analysis based on 1 trial. So I find that to be very interesting. So there's actually 2 studies in the systematic review, but it's in-build, and then it's the in-build subgroup analysis, which is still in-build actually. So based on that, we suggest, the data are pretty convincing, the trial is well done. We suggest an incentive to treat progressive pulmonary fibrosis, and everybody that voted in favor. And so there is a conditional recommendation based on low quality of evidence. 3 people abstained, either based on insufficient expertise or that they felt there wasn't enough data to make a recommendation. So my big concern with this is I think that this was not ready for a clinical practice guideline. I think there was insufficient data to define what this was. It's not transparent how this came about with the definition. Every single paper that I have submitted for clinical research since this guideline has come out, I have come back with a major comment of how many patients manifested progressive pulmonary fibrosis. I'm like, that has nothing to do with my paper. Like, this is getting taken completely out of context, I think. And all of a sudden there's been just this rash of things like sort of describing progressive pulmonary fibrosis using these criteria. I think it has a role. These patients certainly exist and they certainly get worse. To me, this read like a perspective piece as opposed to a clinical practice guideline. And I think that's really problematic because it holds a lot of weight in our field and for our colleagues and our patients worldwide. A lot of these estimates and definitions were extrapolated from IPF, but they exclude patients with IPF. And I think it probably has implications. Pretty big implications. So I like clinical practice guidelines. I think they're very important, but there are some issues. And one is authorship and leadership. And I think there has to be a framework around that. I don't know what that looks like, but there needs to be greater diversity and representation to have different voices at the table because these really matter. The voting and how management of conflict of interests are a little variable. I know that, in certain regions, there are organizations that will create region-specific ones, like France has its own IPF clinical practice guideline. The UK relies on the NICE guidelines. We don't really have that in Canada, so we really rely heavily on these, but maybe we could be having more regionally focused guidelines to be applied to the heterogeneous healthcare systems and practices around the world. The PICO questions aren't always relevant. And I think we really need to focus on, I've invented this word, I hope you like it. It's called implementomics. So that brings people like me into the omics world, where we can focus on implementing these guidelines so that the wheaty components of them and the helpful information are actually getting disseminated to our clinical community colleagues, and so that our patients are benefiting from some of the strong evidence-based recommendations. So I think we really need to focus on that knowledge translation to get these uptaken. And my brain is full, and I've kept it to less than 45 minutes for Dr. Mathe, and I hope you're proud. And that's the thing. So you can all come and visit me in Calgary, and I'll take you hiking out in the Banff Mountains, where I enjoy being. Thank you so much for your time.
Thank you. That was fantastic. And I've learned so many new words. Some of them are real and some of them are not real, but I'm sure the not real ones will also be included in the literature. I love that you actually said out loud a lot of things that people have been thinking. So thank you for that. Any questions? Does anybody have questions? Dr. Siegel?
Thank you for a really good talk. And, I think a lot of what you discussed when it comes to guideline committees extend well beyond IPF. And you can say about any other lung disease or diseases for that matter. And so I'm wondering about your thoughts about how we even select who joins these committees, because I think if the ultimate purpose was to get at truth, somebody would probably have to think about who's at the table. And I just know how these committees they're kind of ad hoc in some ways, and not just gender disparities, like who knows who, and who's well known. And so I'm thinking about something like, for example, I'm familiar with some cognitive observations that have been made about how men and women achieve confidence. And like one of the observations has been that men tend to be more confident, but also confident about being wrong. which is a problem. So I'm wondering how you think about not just gender representation, but ethnic diversification, but also even just diversification in terms of perspectives on the questions, right? If you get everybody together, like maybe that's why ACCP and ATS comes up with different guidelines, because different types of people are more embedded in one organization or another. So if in your ideal world, how would you put a committee together?
Boy, but I think everybody could probably hear that online, but I was just asked to repeat the question. So it's essentially like, how do you put together an ideal committee to meaningfully address these clinically relevant questions that are diverse and representative? Boy, that's the gold nugget, I think. And I've been working with this organization, the Action for Pulmonary Fibrosis, on a different project. Their degree of patient participation and engagement has been so impressive. And I think, when I'm reading through some of these recommendations or the standards, I think having patient voices is really important. And what happens, I think, in a lot of these guidelines is that if I showed up to something like that, I would feel very intimidated. I'm not sure I would stop the entire guideline committee and say, I disagree with everything that you're saying. So I worry that they're present, but they may not have the voice. And that actually there should probably be a lot more effort and work that goes into even asking the field, what are the questions that you want answered right now? And then asking patients, what matters to you and what questions do you want answered? And maybe I don't know, if using a survey or a Delphi kind of a process or focus groups to understand that. And it would take a lot longer. I think that's the thing. You're not going to get all that work done in a 1 year, 2-year time period. But I think setting the framework for questions that actually matter. And also I think some of these guidelines get updated when they aren't necessarily ready to be updated. So there needs to be a little bit of sort of supervision or group voice at the table that is separate from conflicts of interest, and not financial. I mean, intellectual and career development conflicts of interest. Certainly those come into play. So I think if we could ask the people who are impacted, really asking the stakeholders, because putting these committees together and thinking we're the stakeholders when we're on them, and there's weird power dynamics in the middle of a Zoom call or in a room, is not necessarily addressing that in that way. So I think, I don't know what the ideal solution is, but I think it's probably multiple layers and keeping it separate, having patient voices strong methodological representation, which they have in the ATS guideline process. But they present a lot of the data present it for what it is, but don't necessarily vote on the recommendations. And I think having methodologic expertise mixed with content expertise is going to help that. Because I don't know if you could just get completely neutral people in a complex field like this. It's really hard. Well, maybe you can, I don't know. Maybe if we would make it less complicated if we had more neutral people involved. Yeah.
Dr. Jane?
Thank you so much for that amazing talk. And I think my question kind of follows from the discussion we just had with Dr. Siegel's question. Like you've been enamored by regarding clinical practice guidelines as the ultimate sort of epitome of truth. But in the past year, as I've gotten more of an insider's look as being involved in guideline development through proposals at the Critical Care Planning Committee of the ATS, one of the things I'm curious how you grapple with is the evidence to build these guidelines. So as we've been reviewing proposals and building proposals, to include perspectives from diverse settings, especially low and middle income countries, it's like you could put them as a PICO question, but there is no studies. So you'll come out with just nothing. So I don't know what the solution is again, but I'm wondering what your thoughts are on all these different kinds of documents and how a practice guideline should inform a research statement of need, or what that can look like to actually, I mean, by themselves, guidelines are a summary of the state of evidence, which, you know, if there is no state of evidence, you come out with nothing.
Yeah. Sounds like you're in the trough of disillusionment. Yeah. It gets better. Yeah. And so the question was essentially just like, how do you make these representative to the global community? And the evidence really does not come from the global community. Yeah. And I think that must be something that's on a societal level. And it's funny because I come to the American Thoracic Society as a Canadian and I'm like, do I belong? Am I a member here? We all belong, right? But a lot of the sessions are about things that are very specific to the United States. And then I'm like, well, it is called the American Thoracic Society, even though it is like an international organization that is like welcoming, but the main components and the main membership are coming from the United States. And so I don't know if it's a societal issue also, like with the European Respiratory Society, like they're very focused on how things happen in Europe, and that's sort of their mission statement. But I don't know if that's something where we need to define that in a different way somehow, or if ATS is supposed to and openly is to represent the global community, because you know, a lot of these medications even aren't available in places like Brazil. And so if you make this recommendation, none of this is applicable. So I don't know how you get around that. And then it's great to say, well, it's not great. Actually, it irritates me when people are like, oh, we should just do what they do in the UK with like the NICE guidelines. And you're like, that's only in the UK because you guys have like all these resources and history to do this. Like no other country can do it. So it's not like you can say, oh, well, you know, Guatemala should make their own clinical practice guidelines on this. They're really looking, I think, to these international societies for guidance and support. I don't know if anybody else has any other suggestions on that. Oh, Kerri, do you have the answer? Okay.
Area, but may not actually have clinical experience with the problem, or they may have clinical experience with a very narrow group of patients that they happen to see. And so, and usually the most talkative and that people may actually sometimes have the least actual experience. So it can be a frustrating experience. And I think it just gives people pause when they read any guideline. We probably give it more weight than we should sometimes. You know, that the more you know about a subject, the less confident you are when you read some definitive document on it. But thank you.
Yeah, and as you were just saying that, I was wondering, I mean, I'm not part of an NIH study section, but I would imagine that you put a lot more time and effort into reviewing a proposal as a grant submission than any of these, but they're funded. You know, these proposals for guidelines, they're proposed, they're peer reviewed, they're funded and supported similar to a grant would be, and that maybe the whole process just needs to take a little bit more time, effort, thought, and external review before it's approved and gone through.
Dr. Antonis-Circus?
Thank you for that. That was a really great talk, and we struggle with a lot of the same issues. And so given that this is what we have right now and that they're not all bad, I'm curious just on a practical level, what do you do in your practice when you have a patient and you have two different guidelines that might equally apply to them? Somebody with a mid-range exposure, do you go through the IPF guideline? Do you go through the HP guideline? Do you do both? You know, I'm just curious how you approach that.
That's a good question. Well, and honestly, I've been thinking of proposing a guideline on the diagnostic approach to a patient with suspected fibrotic interstitial lung disease, which we have in Canada, but nobody reads it because it's not on PubMed. But yeah, it's funny because these guidelines, that's the other thing. So these guidelines are meant to be, so if you read like in a patient with, and the old one said suspected IPF, and the HP ones in a patient with suspected HP, should they undergo? And then you're like, okay, so first of all, I don't know if they have suspected HP because they just walked in my clinic and I'm not sure. So it's already assuming a level of sort of diagnostic process that you may not have reached yet. So I think that's a big area of confusion. We all kind of hand wave around it. I'm not sure I apply a lot of the guidelines anymore. The biggest one, you know, in IPF, if I think somebody has IPF or I don't think they have a connective tissue disease, do I send a myositis panel on them? Like the guideline says I should. I don't like to because I'm going to get something positive back. And this person is 80 and has a UIP pattern. And I didn't want anything to do with that Joe one that's now weakly positive and they are completely not weak. And so I think I kind of pick and choose from all of them. But I think it brings up this other issue of like UIP. UIP was defined in the context of evaluating for IPF. And then when we see somebody with scleroderma and we say they have a probable UIP pattern, that wasn't meant for those patients. You know, even the radiologic definition was defined and characterized in the context of certain diseases. So it's similar with this, you know, fibrotic HP. Why would we, if I'm seeing somebody that I know just had like chemotherapy and now has like this pattern, am I going to say they have a typical fibrotic HP pattern when I know they have drug-induced pneumonitis? It's hard to know where to apply these. And I think that's, yeah, probably need a framework for that. We don't have. So I
Dr.
pick and choose.
Thanks. Yeah, this was a fun talk. And so I think one thing is really simple. Guidelines have evolved from basically senior old men's clubs, right? That's the way it was. They used to meet and have a cigar and have a drink and decide how we treated medicine. And then there was an effort to make them scientific, right? But they're still the same thing. They're groups that are defined by exclusion. So the people who are not in it are actually the people who notice the guidelines. So I think one thing is we could easily democratize, but the whole community does what, I don't know how many PFF centers, all the members of these centers can vote on the guidelines. Very easy. That's a questionnaire, right? So you could make it completely democratic, the small group, and they discuss and they come up with the recommendations, but then you open it up for the public, the government does it. And basically by the way that people comment, you already know if you have an issue or not. So I think we could democratize it in a relatively low-cost way. The other thing is somebody who has actually practiced overseas, guidelines are really important because when you're in Israel and you need to convince the central committee who approves a drug, like because they force all the HMO, they don't look at FDA approvals, they look at guideline documents. And even in recent years, I've used it because somebody was rejected something. And then you say, oh, it's progress. They invented term now, the progressive pulmonary fibrosis, which has nothing to do with the disease, helps you to get them through. So guidelines are really important actually to a lot of countries in the world because of this idea that there is but I would more interested in your implementomics. So what would it be? Do you redefine the questions based on their instead of PICO questions based on really what would be implemented and what would not, or how would you actually do it?
I think I was just from an implementomics perspective, just getting at a knowledge translation and education perspective, even, so even if it were based on PICO questions and those recommendations get out there, how to make sure that they're being implemented and seen by the practitioners so that they're affecting the patients. That's what I was thinking of.
Because for instance, I really like the lung cancer screening guidelines because although we criticize them, they generated a lot of data and they're really careful about the language and how to make it implementable in a sense and not dependent on the intuition of the physician.
Yeah.
So
Yeah.
There's a way actually to do implementation science to make the guidelines more implementable.
Yeah, that's a really good, and I think the flip side of that is I've reviewed kind of manuscripts over the last several years that we'll use a guideline and then we'll look at a health system or a registry and kind of rate it on how well they're following the guidelines. And they will say, is this person on oxygen? Have they been to pulmonary rehab? Have they been referred to a transplant program? But you weren't in that clinic. So that's the thing where like, we can't, we're saying use your clinical judgment. So I guess, we're saying all these things are recommendations, but you need to apply them on an individual case by case basis with discussions with your patients. So maybe we can't make sure they're implemented because a lot of people don't want to be referred to transplant, or some people are fit enough, they don't need to go to pulmonary rehab, or they've declined vaccinations, or so you weren't in the room and you can't really measure that. You can measure it, but they tend to come with judgment that people didn't meet guideline recommendations. But again, they're not mandates. So I think it's tricky to know which ones to implement.
Oh, okay. Yeah, Dr. Homer commented on, what did they say? The same could be said of pathology representation on these guidelines as well. So that's good. He wasn't here. Well, I think you finished at exactly 4 o'clock. Made us all proud. So we have so many more questions for you, but thank you. This was really a fun talk.
All right. Thank you so much.
Take care.